Hello, everyone. Thank you for joining us today for our webinar entitled Using QPP Data Analytics to Impact Strategic Decision-Making and Maximize MIPS Scores. Today's presenters are Bruce Mackey, Alterum's Regulatory Analyst, and Jacob Makowski, Alterum's Senior Health Informatics Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. A PDF copy of today's slides can be downloaded right now from your GoToWebinar interface. We will be keeping everyone muted during today's presentation. If you have a question, please type it into the questions box in your GoToWebinar interface, and we will address it during the Q&A. Because of the large number of attendees for today's webinar, we may not have time to answer all of the questions. If we do not address yours during today's broadcast, you will receive an answer through email. Also, a link to the recording of this presentation will be available by midday tomorrow on the homepage of our website at qppresourcecenter.org. Today, Bruce and Jacob will provide a brief overview of the Quality Payment Program, the MIPS final score, its relation to the minimum performance threshold needed to avoid a penalty, and what participants need to understand their performance while improvements can still be made. From there, they will take turns discussing various topics within the merit-based incentive payment system, including how to determine if participants should individually or group report, the 4 performance categories, and the MIPS final score, providing considerations and best practice advice based on program experience and informative data analytics. Following the presentation, we will take time to answer any questions posed by the attendees. With that, I will turn things over to Bruce.
Thanks, Liz, and thank you everybody for joining us today to talk about the Quality Payment Program and specifically all of the things that you can be doing and analyzing and taking a look at to ensure that you're maximizing your scores. I'll start out with just kind of a brief overview of the Quality Payment Program. This came to us through the MACRA rule of 2015. Although MACRA had a whole lot in it, the main thing it brought to us and what we're talking about today is the Quality Payment Program. Within the Quality Payment Program, we have those 2 paths of participation. Folks are either in the MIPS track, and that's where we see the majority of folks at this time, in the Merit-Based Incentive Payment System, or MIPS. And then we also have the Advanced APM track, or the Advanced Alternative Payment Model track. One thing to note here is essentially, though, everybody, regardless of what track you're in, everybody is reporting the same data. It's just really comes down to where that data is coming from and how or if it's being scored. But really, regardless of the path you're in, all of that same information is making its way to CMS in some way, shape, or form. So within the MIPS track, which is what we're focusing on today, and all of the performance categories within it, we have the 4 performance categories. We are using all 4 of them this year. Last year, we only used 3 out of the 4. They did not assess folks on cost, even though they provided some feedback in the cost category. But we have these 4 categories. We have the quality category, we have the cost category, we have the improvement activities category, and the what's now known as the promoting interoperability category. Last year, it was known as advancing care information, or ACI. It's really just meaningful use. That's another term everyone is very familiar with, as we've been working in that program for many years. But the PI performance category is really just meaningful use scored differently. So what we're trying to build here throughout the MIPS path is the best MIPS final score possible. Each of those categories, which in and of themselves are very complex, which you'll see as we go through each one of those, you're building points within each category. Each of those categories then contribute to that final MIPS score. It can be as high as 100 points. If you're hitting 100 points, you're getting the best Medicare reimbursement rate you possibly can for that program year. But each of the categories don't contribute evenly to that final score. We have what's called the performance category weighting. It was different this year than it was last year, and we will see these performance categories shift over time as well. This year, the quality category is worth 50%. It's worth half of that final MIPS score. The cost category is being assessed at 10%, being the lowest amount. improvement activities is 15%, which is what we saw last year, and promoting interoperability is 25%. Over time, we're going to see the cost category increase in weight and the quality category decrease until they are both at 30%. I think it's going to take us a few more years to get there. But really then you are consolidating, you're taking the data that you're contributing under each one of these categories, combining it all through this sort of weighted average, and it all contributes then to that final MIPS score. That final MIPS score is then compared against a minimum performance threshold, which we'll talk about, and then depending on how your score compares to the performance threshold, you are either going to see your Medicare reimbursement rate stay the same, hopefully increase, and hopefully not decrease if you are below that threshold. So in terms of that threshold then, we saw it increase significantly from last year to this year. Last year it was a meager 3 points, which really just about any data you submitted got you that minimum 3 points. It's a little bit higher now. You have to be at 15 points to at least negate that payment penalty. And we're going to see it increase again come next year. Right now, the proposed threshold is 30 points for next year. I suspect that will get finalized later this year, but we won't know that for certain until the final rule comes out, probably around November-ish or so. And then from there, we're going to see it go up year after year. In a few years, it's going to become the average performance of the prior year. So we'll get into this a little bit more when Jacob is talking about the data analytics. I am guessing that in a few years, that minimum threshold is going to be in the 70-point range because that's where folks are, the averages are coming in. Folks are traditionally doing fairly well if you're fully participating in this program. And as we get deeper and deeper, we're going to see that bar raise every single year. And when it starts to become the average of the prior year's performance, we're going to see a massive jump in that threshold. So right now, CMS is setting that threshold for the next couple of years. So next year, it's probably going to be 30. Year after that, it might inch up a little bit. Fairly soon, we're going to see a significant jump. But you can see kind of what your final score means in terms of the Medicare reimbursement rates. So another option to consider or add some additional complexity to this program is the reporting options. Folks can report as an individual in this program. In this program, each NPI and tax ID number or TIN combination is seen as a separate program entity. So if a provider works for multiple organizations with different tax ID numbers, their performance under each of those TINs is assessed separately. And that way, one TIN can't affect the scores of another TIN. Folks under a single TIN or those that are participating in any type of ACO, they can also do group reporting. It is optional for those that are not in those what's called an APM entity here on this screen. When you see APM, you can essentially think ACO. If you are in an ACO, you are locked into group reporting. You cannot get around that. There's no option there. You will be assessed. If you're in an ACO, you're going to be assessed at the ACO level. That is a large group that's going to contain the data from all of the tax IDs or all of the providers that are participants in that ACO. But for others who are not in that ACO, they can optionally participate at the group level. And there are a lot of considerations there to determine whether participating at the individual level or participating at the group level is more advantageous in terms of getting you the best MIPS final score and subsequently the best Medicare reimbursement rate. There's also another option this year that became live is the virtual group. A virtual group is a group of solo practitioners and groups with 10 or fewer eligible clinicians who come together virtually. So the best analogy I can bring here to shed some light on what a virtual group is, you can think of a virtual group as sort of a mini ACO. It kind of works in the same way. You know, an ACO is a group of clinicians or a group of tax IDs that have come together to work together towards higher quality and lower costs. A virtual group essentially does the same thing. It is a collection of providers or a collection of small practice providers that have come together and are banding together and are consolidating their data in much the same way that an ACO does as well. So again, it just adds complexity to what is already a complex program, is trying to decide what makes the most sense there. So in this very complex program with all of these moving parts and all these variables that you really need to consider and fully understand to be able to maximize those scores, really what's needed then is these clinicians and organizations need to track these several categories of information. You need to understand the performance changes over time. There's things you can be doing to increase those scores, and you need to understand how those are affecting those final scores or individually those category scores. You need to evaluate the different reporting options to determine the best approach. I'm going to get into that also. The different reporting options available can have a wide-ranging effect on your MIPS final scores. Then you need to be identifying those areas of strength and weakness within your practice, going from provider to provider and tracking the effect of those improvement efforts to determine whether what you're trying to do is having the effect you're hoping it does on your category scores and your MIPS final score. So really then a potential solution, or one that we would highly recommend, is for those clinicians and orgs that need to do all of this and organize and evaluate this data, you need to be able to put them in the proper context to maximize those MIPS scores. So a potential solution then is to use some sort of data aggregator, some sort of program that can put all of this together for you.
So there are several applications available to calculate MIPS program scores. Some examples include MIPScast, MyMIPS Score, the Stratus Health MIPS Estimator, and the Purdue Healthcare Advisors MIPS Calculator. Today we'll be reviewing the analytic capabilities of MIPScast, a MIPS forecasting tool that is being used by thousands of clinicians as part of the Great Lakes Practice Transformation Network, the Quality Payment Program support for small, underserved, and rural practices, and through commercial access. We've collected data through manual entry and electronic file import and have analyzed over 2,000 MIPS score predictions. Now Bruce and I will take turns discussing various elements of MIPS, providing overviews, considerations, and best practices based on program experience, as well as the data we've collected thus far in MIPScast.
So we'll start off by talking about that one place that you need to look at is deciding, does it make more sense for my providers to report individually in this program, or does it make sense to band together and do the group reporting option? There's no easy answer here. There's a lot of considerations to keep in mind. What works for one tax ID is not necessarily what works for the other tax ID. One thing you might do is consider the differences in Medicare volume relative to those MIPS scores. So if your top performers in this program, meaning those that are getting the best MIPS final score on their own, also bill the most Medicare, group reporting could actually hurt your bottom line, because those top performer scores are going to drop when aggregating the scores with the lower performers. When you group report, you're banding all of that data together across all of your clinicians and sending one data set to MIPS, to CMS, and everybody there is going to get that same group score. But if your lower performers bill the most Medicare, group reporting could really be advantageous in that model, since they're higher, since the higher scores, the scores will rise due to the higher performers. So overall, the bottom line could be increased there by those higher Medicare folks getting pulled up by the group score. So looking at this very rudimentary grid, we see the MIPS scores under column A. We've got those providers A and B that are getting really phenomenally good MIPS scores are also have the highest Medicare volume. We wouldn't necessarily want those folks to get dragged down. In this model, the group score is a 55.6. It'd be far more advantageous for this model for a group in scores A to stay and individually report, because those folks that are also billing the most Medicare are going to get the best MIPS score. So it's the polar opposite if what you're working with is what we have here under column B, where the low performers are also billing the highest. We want them to be dragged up instead of instead of reporting and getting a MIPS final score of 10 or 20, by group reporting, they're going to get a group score of 55.6, which is going to boost the Medicare reimbursement rate for them as well. It gets a lot more complex than that, though, because in the group participation in the merit-based incentive payment system in 2018 resource that you can pull from the qpp.cms.gov website, we see, and look at the second paragraph there in that screenshot, a MIPS eligible clinician participating via a group will get the group score. However, if the same eligible clinician also submits individual level data, CMS will use the higher of the two final scores for that clinician. So with this in mind, the overall strategy is always group report if you can. Then, if an individual clinician is over that low volume threshold, so again, this only works if the individual clinicians can report individually. And just note that this is not an option for ACO participants. If you can certainly send that data to CMS at the individual level, CMS is going to ignore it if you are in an ACO. You cannot get around getting awarded the ACO score if you're in an ACO. So if those individual clinicians can report individually and their individual MIPS score is better than the group average, you want to also report that individual clinician's data to CMS. So with this strategy, those lower performer scores are raised by the higher group score, and then your higher performers are not negatively affected by the lower performers, because CMS is going to look at those two and say, well, the individual score is better here, so we're going to award that individual clinician with that higher score, even though the rest of their group is going to get that group score. So now we'll get into the different performance categories. We're going to start off with the promoting interoperability, or PI category scoring. Again, this is what was called ACI last year, and really it's just meaningful use with some different scoring and a little bit of shifting in the measures. So in PI, we've got some different components here. We have the base score that's worth 50 points. We've got the performance score, which is worth up to 90 points. And then we've got some opportunities to get some bonus points, up to 15 bonus points in the category. All of that goes together to create the performance category score. You max out at 100 points. As you can see there, there's actually 155 points that are available under this model. So you could lose out on a third of the points and still do okay. If you get that 100 points, you get the full 25 points towards your MIPS final score. So looking at the base score, I'm going to draw your attention to the fact that we have two sets of measures here. And you've got some options on whether you are going to use the 2018, what's registered here, the 2018 PI ACI transition objectives. These correlate to the modified stage 2 objectives. This is likely to change once the final rule comes out, but as the rule stands right now, that second column denotes the kind of regular PI ACI objectives. Again, this does not denote the changes we are likely to see that have been proposed but not finalized. What's reflected here is what's currently finalized. Again, I recognize that this is likely to change because they're making some significant changes to the PI category for next year, but again, it just hasn't been finalized yet. So we've got an all or nothing component here. You have to do a few things to get any kind of PI score. On the PI performance score, again, you've got up to 90 points, and these are all of the measures that are reflected in there. You can see under the transition objectives, which is what we see the folks, most participants sticking in the transition objectives for this year. They are still an option. You can use either 2014 or 2015 certified technology here. These are the measures that correlate back to the modified stage 2 of meaningful use. Then we have the kind of regular objectives, the ones that correlate back to the stage 3 objectives, and you have to be on your 2015 version of your certified technology in order to go into those objectives. That is what we'll be doing for next year, so you got to make sure you're on your 2015 technology next year. But this year we still have the option to use either version of your EHR, whether it's certified to 2014 or 15. And we see the most folks sticking with the transition objectives again this year. How's that performance calculated? You're looking at each one of those measures individually. You're going to take your numerator and denominator and convert that into a performance rate. And then that performance rate will give you how many points you're going to earn for each one of those measures. So rudimentary example at the bottom here, if you had a numerator of 85 and a denominator of 100, that's going to translate to an 85% performance rate. And then that is going to earn around 9 out of the 10 points for that particular measure. There are two measures that are worth 20 points. The promoting the HIE measure, which is very difficult to score high on still to this day, and then the provide patient access measure, which is that measure 1 of the patient portal measure, where you're just offering your patient portal to your clinicians or to your patients. So looking at the base score, we have kind of some sort of an average meaningful user here, somebody who's doing okay, and we're going to show you kind of how that scores. So looking at just the base PI category score, we have a clinician doing very well on the ERX measure. They only needed to do 1 in order to get the base score here, but this is what we typically see. ERX is one where the vast majority of providers are scoring exceptionally well on. The VDT access, view, download, transmit access, that's part of the base score. We also see folks doing fairly well on this one. Everyone is sort of in that routine of offering their patient portal to all of their patients. You only need 1 in order to score for the base. HIE, that's sending those summaries of care electronically. This provider is doing unusually well. This is where folks really struggle with this measure. A lot of folks will just take the exclusion, which still exists for this year. If you have 100 or fewer transitions of care, you can take the exclusion. That would still allow you to meet the base. But if you are really counting your numerator and denominator, you only need 1 to get past the base score component. And then everybody always has to do their security risk assessment. So there's no getting around that. That is never going away, but it is part of that performance score. You have to do that to get any sort of PI score. Then we circle back to the performance score, and this is where every numerator counts. Every patient that you are doing that action on or getting the score is going to add to your score for that particular measure. So we look at each of those numerator and denominators. We see this provider getting 25% on the HIE measure, which again is sort of unusually well. The VDT, they're doing great. That 99% performance rate translates to 10 points for that. That is one of the ones that is doubled for the transition measures, so they're getting the full 20 points. VDT use is a sort of average performance there. They've got quite a few of their patients that are actually using their patient portal. That translates to 5% or 5 points. Patient education is another one that's sort of low-hanging fruit. We see folks, most providers doing exceptionally well there. Same thing with MedRec. It's just a natural course of doing business or patient care. So we really see most providers doing exceptionally well, getting the full 10 points. Secure messaging, in this particular example, they're doing okay, but not real well. They really are not making full use of the secure messaging function to communicate with their patients. So they only got 1 point for that measure. And then they did the minimum they needed to do, at least for the public health reporting. They were able to say yes to that one. Any of the yes-no measures, you're either getting 0 or 10 points for that measure. So since they met the requirements for public health reporting, they're getting the full 10%. So here the total performance score is 62% out of a possible 90. So they've left quite a few points on the table there. Looking at the bonus measures, they did go above and beyond, reported to an additional public health measure. They got an extra 5 bonus points there, but they did not get the bonus for implementing certain improvement activities that feed back into to some bonus points here. So they missed out on those. They only got 5 out of the 15 bonus points. Pulling all that together in the scoring example, they got the base score of 50. They got a performance score of 62 out of 90. And they got some of the bonus points, but really they didn't need them. And that's what we often see in scoring, is that bonus points often aren't needed, because with 155 total points, you're capped at 100. So in this particular example, they got 117 out of those 155, but they're still capped at 100. So in this example, this clinician would have earned the maximum points under that category. I use this as an example because I want to illustrate that you don't have to maximize every one of those measures. Work on the measures that are worth working on. Make sure that your clinicians are at least getting 100 points there, and then focus elsewhere. If you're looking to maximize those scores, don't think that you have to get 10 points for every one of these measures. You can leave a third of those points on the table and still get the max points under PI.
So for the promoting interoperability category, MIPS-Cast provides visual indicators of performance while you're entering data, including whether or not you've met the requirements for the base score, the performance points earned, and bonus points earned, while automatically applying rules like measure exclusions when they're applicable. Another benefit of using a tool like MIPS-Cast for scoring your promoting interoperability data is that you have the ability to enter data for multiple 90-day periods, and as Bruce said, evaluate those against each other and pick the highest one, although oftentimes this won't necessarily be necessary. If you were previously a meaningful user, you'll likely get full credit without having to evaluate multiple time periods or even earn any of the bonus points. When we look at the data in the promoting interoperability category, and I should probably pause here and say that all of the data that you're going to see on these slides from MIPS-Cast and any of the descriptive statistics are from 2017 performance period data and predicted MIPS-Cast scores. Because the 2018 performance period is in progress as we speak, I did not include any of that data, but I will highlight where I'm seeing trends in the 2018 data that vary from the analysis provided on these slides about the 2017 data. So the average score observed for promoting interoperability was over 65%. However, just looking at the average doesn't tell the full story. When looking at the distribution of scores, very few clinicians scored between 50 and 80 points out of 100, with most scores either falling into the greater than 90 points out of 100 range or earning 0 points. And so clearly, among those who met the requirements for the base score, the average score was greater than 90 points, and many did in fact earn a perfect score of 100 or earned greater than 100 points and had their score capped at 100 points. So most score predictions that did not meet the base score requirements had some data entered for some of the measures in the promoting interoperability category, indicating that these clinicians or practices were using certified technology, but perhaps were missing one of the required measures, one or more of the required measures for the base score. Our data suggests that most clinicians who meet meaningful use in previous years will earn full credit in this category. And so that's perfectly in line with what Bruce shared in terms of his analysis of the rule. We're also seeing that in the actual data for 2017 MIPS-Cast score predictions. It is, however, important to remember to report all measured data because even measures that did not meet meaningful use thresholds in the past will earn points in the MIPS program. If you previously or are currently not earning the base score in this category, focusing on this category could create a 20+ point improvement in your final score. And this will likely be your primary category with opportunity for improvement unless you are scoring below the 50% mark on the quality category.
All right, so now we'll look at the quality performance category and some considerations here. When you're looking at which quality measures you should select and report on, if you can, you want to first look at the measures that are clinically relevant. You want to look at what's important to you and to your clinicians, what aligns with the practice goals. The specialty measure sets may not be your best option. I think Jacob's going to touch on that a little bit, but what we're seeing there, while the specialty measure sets can help kind of narrow your focus, there's a lot of measures to choose from, 270-something measures. Can be hard to kind of look through that laundry list of measures and find the ones that are specialty specific. You could use those to kind of guide your selection, but they may not be your best option. Regardless of your specialty, you can choose any of the measures. You're not limited to just those measure sets. Registries can also create their own measures. They were called non-MIPS measures last year. And this year they're now changing to calling them registry measures. That caused some confusion, calling them non-MIPS measures, because some folks determined that to mean they couldn't use them for MIPS. So they're doing some name change there. So in terms of specialties looking for clinically relevant measures, you might look to the registries that are available to you too. We often see the registries being able to, especially ones that are specialty specific, they're good at creating their own measures that can then be used in the MIPS program as well. When you're looking at the quality measure scores, if they're low, there's a lot of considerations there. It doesn't necessarily mean that there's really a quality issue. I wish this wasn't the case, but a lot of vendors have these calculating incorrectly. There is a wide range of issues with the certification of these measures, and the vendors are pushing out CQMs that are not calculating correctly. So if a measure is showing low quality, don't just talk to the provider and ask them why they're not doing what they need to be doing. You really need to dive into that measure and get some assurance that your vendor is actually calculating it correctly. Again, I wish this wasn't the case, but we see this over and over again where the vendors are just not programming these correctly. It could also be a configuration issue where the vendor has distributed a measure that's calculating correctly, but oftentimes they require some setup on your side. They need codes, some LOINC codes that are mapped. We often see this where there's something just not configured in the background. And so the measure is trying to do what it's intended to do, but it's not being provided the data that it needs. And just some quick configuration issues getting fixed can then generate accurate quality scores. Also data entry issues. It could be depending on what the measure is trying to measure itself. Let's say if it's a process measure, but in the stream of patient care, somebody's not clicking that radio button or not checking something in a checkbox, that could, the care is being provided correctly, but it's really just a data entry issue. You can talk to your staff, make sure that everyone knows where they need to be clicking in your EHR, and then that quality measure is going to calculate properly. All those aside, you actually could be dealing with a quality issue where, especially on the outcome measures, your diabetics are out of control with their A1C, but don't just look to that first. If you're seeing low quality numbers, really dive into those quality measures and make sure that all your ducks are in a row, that the vendor's doing it properly, you've got it configured properly, and you're entering that data properly as well. The other two options here are considerations, the data submission options. It really matters under the quality performance category. There are different ways to get that data to CMS. I'm going to touch on that. I'll touch on what I mean by the benchmarks, and then and that there are more options under the registry than there are the EHR ECQM. I'm also going to talk about topped-out measures on the next few slides as well. Important considerations. So first and foremost, we want to look at those data submission options. You can see there's a lot of different ways to get your data to CMS. There's some differences between whether you are submitting as an individual or as a group. For the most part, for 3 out of the 4 categories, it doesn't matter how that data is getting to CMS. The score that you get is the score. It doesn't matter, except for quality. It makes a huge difference on how you're getting that data to CMS. The reason for that is relative to the benchmarks. So I know there's a lot of numbers on here. I'll try and walk you through this. If you look at the top, we see what the formula is for creating your performance rate. In this example, we have a performance rate of 62, sort of average performance on any quality measure. So under claims-based reporting, which is green, you can see where we have different benchmarks set for each submission method. So the benchmark is what you're being measured against. So depending on what your performance rate is, the number of points you get on that measure is relative to how your performance rate measures up against the benchmark for that particular measure. There are, however, different benchmarks between submission methods. Benchmarks are set off of the average performance in prior years. And there is a wide range of performance that is reported depending on how that data is being sent to CMS. So claims-based reporting, in this particular example, for Measure ID 110, the preventative care and screening for influenza immunization, that performance rate of 62 is going to give you 5.96 points. But if you use EHR-based reporting, reporting through an ECQM, that's going to give you a much different score. So exact same performance of 62 under that submission method translates to 8.90 points. And then registry, which is again a different benchmark, exact same performance. You haven't done anything different other than gotten the data to CMS in a different way. That exact same performance would give you 6.64 points. So that's a massive difference, especially when you are submitting that minimum requirement of 6 measures. You can see that just how you send that data to CMS could have a very significant effect on your MIPS final score. Then we'll look at topped-out measures. This also can have a dramatic effect on your quality measures, depending on your measure selection. So a topped-out measure is one where there are no longer meaningful distinctions between the highest and lowest performers. There are a lot of measures that have been topped out. In fact, the vast majority of those 271 measures available are either topped out or they're approaching topped out status. CMS has now deemed for this year, measures that have been topped out for at least 2 consecutive years are going to be capped. All the rest of the measures, you can get up to 10 points for that measure, but these topped out capped measures, you can only earn up to 7 points, regardless of your performance. So there are 6 measures that are topped out for this year. This is them. So if you are selecting to report on any of these measures, just know that perfect performance is not going to get you 10 points. You're only going to get 7. So if you are doing all of these, you're going to significantly hamper yourself in your quality category score. But you have to take it a step further. It's not just the topped out capped ones that you should be concerned with, because if it's just topped out but not topped out capped, it's still really hard to get a good quality score for that particular measure. So look at CMS 68 here. You look, these ones, this is not one that's topped out capped, but it is topped out. So you can see if you're doing claims-based reporting on this measure, look at the deciles there signify the range of points you can get for that particular performance rate. So under claims-based reporting, you can get somewhere in the 3-point range, 4-point range, 5-point range. Near perfection is still only going to get you somewhere in the 5-point range. And then you have to be absolutely perfect. Your performance rate has to be on par. You have to do it right every single time to get those 10 points. So one small mess up with one small patient, you didn't put that G code on one of those claims, you're going to drop all the way down to 5 points. So again, if you're picking a lot of topped out measures and it could look like you're performing exceptionally well, but if it's topped out, you're going to significantly lower your quality score. And then even ones that are not yet topped out, a lot of them are approaching topped out status. So CMS 2, for example, if you're doing claims-based reporting on CMS 2, again, if you are not absolutely perfect, at best, you're going to get 7 points for that measure. So just be wary of those quality measures. Just looking at your performance rates and picking all the ones you're in the 90s on doesn't necessarily mean those are the best ones to report on. You really need to take it that step further. Grab that quality benchmark file. I've got the link here on this slide. Grab that quality benchmark file from CMS and really look at the measures that you're performing on and how are those going to stack up.
So as Bruce mentioned, you can't just look at your quality measure and say, I'm at 95% plus performance, this must be a good measure for me. You need to consider that measure, how it's being collected and reported, and then determine how it scores against the benchmark. There are also many other rules to consider when scoring a quality measure. MIPS provides quality measure scoring feedback for each measure entered into the system, including reporting method-specific benchmarking and checking for other specific rule criteria, including required outcome or high priority measure reporting, data completeness, minimum cases, and whether or not bonus points are earned for a particular measure. The average quality category score was greater than 60%. The scores for EHR measures were on average higher than registry and claim scores, but the required outcome measure was reported most often via claims. This isn't surprising just based on the benchmark data for EHR, registry, and claims measures, with the EHR benchmark often being, on average, lower than the registry or the claims benchmark for the same measure. Reporting using a specialty measure set almost never resulted in a higher score than including all measures available. Because of the way the rules are structured, reporting measures that are outside of your specialty may actually earn you a higher score than only sticking to those that clinically apply to you. Additionally, reporting measures beyond your top 6 measures that are included in your score can also earn bonus points. So it almost never benefits the clinician or practice by rule to limit the number of measures they're able to report. And this is also something we saw in the data, with only 2 instances, or 0.2% of the scores being the highest score for the clinician with a specialty measure set. Not reporting the required outcome or high priority measure when available affected the average score for the category more than expected. This is because the clinician loses up to 10 points for the required measure they didn't report, and also limits their ability to earn additional outcome or high priority bonus points for subsequent measures that they've reported. Some key tips for improving quality category scores are to focus on just a couple measures. It's not possible to improve your quality or your process in your practice for 10 or 15 measures. So you really need to narrow your focus and identify just a couple measures where you have an opportunity for improvement. These are usually going to be your 5th or 6th highest scoring measures, with the idea being that your top few measures you're not likely to improve in because you're already scoring well on them. You also need to pick measures that are not already near 100% in the performance rate. There's no opportunity to improve your performance there. You don't want to select a measure that's capped or topped out, or as Bruce mentioned, while not technically identified as topped out, essentially already topped out, because you need to score in the 90% plus range to get a good score for the measure in the MIPS program. It's also good to identify measures that may be improved through just better documentation or by addressing some of the issues that Bruce identified earlier. If you can make a configuration change in your EHR, map an additional LOINC code, or address a process in your office so that documentation on a particular measure is better, you may see a drastic improvement in a particular measure's score that better reflects the quality of care you are already providing. An example you can see on the screen now is that, if you could actually go back one slide there, Bruce. Sorry, jump forward one. I want to make sure we're on the right screen. There we are. Sorry, just out of sync for a moment. In the upper right-hand section, you can see that MIPScast has scored several measures and provided information about the numerator, the denominator, the percentage, the decile points, and then also whether or not they received any outcome or high priority bonus or electronic end-to-end bonus points. In this example, if I were consulting with a practice, I would say first, to determine whether or not there is an outcome measure available to this clinician or practice that they can report. They're currently not reporting one, and this is costing them at least 5 points, because even reporting a measure that they're not performing well on would earn them the minimum 3 points, and then would also allow them to earn the bonus points for measure 238 and measure 130 that they're already reporting. I would advise them not to focus on measure 130 because they're already at 84.9%, and while they can improve, they would need to get at or near 100% on measure 130 to get a higher decile score, because the benchmark for that measure is already so high. Measures 317 and 431 are both screening and follow-up or counseling measures, where improvement can be made in some cases just by improving documentation or implementing new processes in the office. So those are the measures I would focus on for this clinician or practice. Also, if you're submitting only 6 measures, you're going to limit your availability to earn additional bonus points for measures beyond the 6. There are also instances where a measure may not have a benchmark and is only scoring 3 points, and therefore isn't in your top 6 measures based on its current score. But if you submit that data to CMS and CMS establishes a benchmark, your score for that particular measure could be much higher than the minimum 3 points. Then if you could jump back to the slide you were on earlier, actually, Bruce. So again, just in summary, be sure to report all available measures. Measures beyond your top 6 can earn bonus points. And again, if you report a measure that doesn't currently have a benchmark, it may be worth more than the 3 points that you're guaranteed as a minimum. Not reporting an outcome measure can really hurt your score, both because you're losing the points for that measure and you're affecting your ability to earn additional bonus points. And you should always take advantage of reporting electronically end-to-end if possible.
So we'll look at the improvement activities performance category next and some considerations there. So it's worth 15% of your final score this year, same as last year. There are 112 activities available to choose from. When you attest to the activity being implemented, what you're telling CMS is you had it implemented for at least 90 days in the program year. And if it's still implemented between last year to this year, you can attest to the same activities year after year. So you don't have to pick new activities. If that same activity that you attested to in 2017 is still in place for at least 90 days in 2018, you can attest to having that activity again this year and get that credit. To maximize the category, you need to earn at least those 40 points. Each one of those 200 or 112 activities is worth either 10 points if it's a medium weight activity or 20 points if it is a high weight activity. But the point values are doubled for the small practice clinicians or groups. A small practice is 15 or fewer billing clinicians. It's not just the eligible clinicians. It's not just those folks that are on the hook to report to MIPS. It's looking at all of the clinicians at year 10 that are submitting Medicare claims. That often means there are quite a few others, so you have to look at that. So anyone who has 15 or fewer of those folks billing to Medicare, the point values are doubled. So they're worth 20 points for medium and 40 points for high weight. So a small practice clinician or group only has to report on a single high weight activity to get the full 40 points. It's a simple yes when you're telling CMS that you've implemented this. You're just saying yes to that particular activity. It's sort of the honor system. It would get picked up in an audit if you can't prove that you had that activity in place for 90 days in the calendar year. Certain improvement activities do earn PI bonus points. I think there's 19 of them or so that are tied back to the PI category, meaning if you are implementing that improvement activity by leveraging your certified EHR technology, it's going to earn some bonus points back on the PI category. But as I just mentioned, you may not or probably don't really even need those bonus points there either, because if you're meeting those meaningful use objectives, you're probably doing just fine in PI without those bonus points, as the example I shared showed you as well. Something else to keep in mind that if you are group reporting, it's the same for virtual groups. Only one clinician in the TIN or in the virtual group has to perform that improvement activity for the entire group to be able to receive that credit. And they made a change for the PCMH for folks that are PCMH certified or recognized. Last year, only those that were certified as PCMH were able to claim this credit. This caused a problem with the PCMH neighbor program, the side of the program that is designated for the specialty providers. They could not, there was no certification for PCMH neighbor, so they changed the terminology for this year. So now it's anyone who is recognized as a PCMH or comparable specialty practice. Those folks get automatic credit in this category. And then additionally, 50% of the practice sites within a TIN or in a virtual group need to be recognized as PCMH. If that is the case, then the entire group would receive, or the entire TIN would receive that full IA category credit.
MIPS allows for entry and scoring evaluation of improvement activities and accounts for scoring rules related to small practices, rural or health professional shortage areas, patient-centered medical homes, APMs, or those participating in a CMS study on burdens associated with reporting quality measures. The system allows for the clinician or practice to select the activities they're participating in, indicates to them whether they're high or medium weight, and then scores them appropriately. The average score for the improvement activities category was 95%, and the most common activities selected, other than TCPI, which was a common selection of the GLP-TN, were 24/7 access, the CAP survey, tobacco use, and depression screening. Also, 62% of those who have scores for indicated that they were a small, rural, or HPSA practice, and 9% indicated that they were participating in a PCMH. So most clinicians or practices were able to get full credit in this category. Those who scored 0 points in the category may not have actually scored that in that category when they attested to CMS, but just didn't document that they were participating in any improvement activities in the MIPS system. Practices and clinicians analyzed were mostly TCPI or GLPTN participants, or were small rural or health professional shortage area practices, and they're choosing these activities. Provide 24/7 access, participation in the CAPS supplemental questionnaire, tobacco use, depression screening, practice improvements for bilateral exchange of patient information, implementation of use of specialist reports back to referring clinician, or consultation of the prescription drug monitoring program. Based on the nature of the clinicians and practices that are using our system and the most frequently selected improvement activities, our data suggests that these may be some potential options for a practice to implement if they're looking for their first improvement activity to implement. So these may be some low-hanging fruit to select and participate in this year and in subsequent years.
Looking at the cost performance category, it is worth 10% of the MIPS final score this year. We are going to see that increase over time, as I mentioned on the front end of this webinar. Eventually, it's going to be worth 30%. They've proposed to use 10 episode-based measures, but they adopted in 2017. Those are not being used this year. So what you're being scored on is the same measures you received feedback on if you participated in the program last year. So there's only 2 measures that are going to be assessed to generate your cost performance category score. It is the Medicare spending per beneficiary, or MSPB measure. There is a minimum threshold. You need at least 35 cases to be scored on that measure. The second measure that they are using is the total per capita cost, or TPCC measure. That has a minimum threshold of cases of 20, so you need at least 20 cases that are attributed to you there. If only one of those can be scored for a clinician or a group, that will serve as the category score for cost. And if neither one of them is applicable to a provider, which we absolutely do see as well, this year we'll see that 10% shift back to quality. So if that happens, your quality score would be worth 60% of your MIPS final score as opposed to 50%. This is calculated off of administrative claims. So there's no additional submission requirement there. CMS is looking in the background, and all of those Medicare claims that you're submitting, you are being assessed on each of those measures if they apply to you. There is some prior year data. So you can look back if you're trying to gauge where your practice is at and how we're doing on quality. You can look back on the quality resource use reports, or the QRURs, those PQRS feedback reports that we've gotten if you participated in the PQRS program in years past. You can go to the qualitynet.org website and grab your prior QRURs. That is a good way. There's a lot of great practice level detail there that can help inform you and tell you how you're doing in cost. Unfortunately, while CMS provided some cost level feedback in this year's MIPS feedback reports, it's really lacking. There's just really not enough there to really get, to dive down into those measures and really understand them. You can see if you got scored on them and what your cost score would have been had that been included in the weighting for your MIPS final score. But we're really lacking the amount of information that you need, and you're lacking the data at the provider level, which is how you're being scored if you're reporting individually. So CMS is working on generating better cost level data for you guys, but right now it's really hard to assess where you're at in terms of cost. There's no real good way. The best advice we can give is to look back on those past PQRS reports. Definitely look at the cost feedback information you got in your 2017 MIPS final score reports. But overall, we just are right today. I just don't think you guys are getting the level of cost detail that you need to be able to affect and know which providers need to be working in the cost category. One piece of advice, though, is to look at those quality measures that are related, that can affect those cost measures as well. And that way, by working on those quality measures, you're kind of double dipping. So improvements in those quality measures are also going to affect your cost performance category scores. And then something else to keep in mind, maybe this is the best piece of nugget we can give or point out, is that it's only worth 10% this year. So a significant or notable 10% increase in the category, which I'll tell you is almost unheard of. We really don't see the cost measures changing all that much from year to year. So if you were somehow able to just hit this one out of the park and make a 10% improvement in the cost category, because it's only worth 10% of your MIPS final score, you're going to increase your MIPS final score by 1 point. So until it's worth more and we know more, improvement efforts may be better focused in the areas with greater impact. You know, we can't work on everything. So work on those areas that are going to give you the greatest impact in your MIPS final score.
So now that we've covered each of the categories, we can focus on how those categories are combined into a final score, or as Bruce referred to it earlier, kind of as a weighted average among those 4 categories. As Bruce mentioned, the cost category, we really only have access to historical data for the practices and clinicians. So in MIPScast, you can enter data from your prior year cost measures and then use those as a sort of placeholder score to include in your current reporting year overall score, with the assumption being that your cost score is not likely to change much from year to year unless you make some really big improvements, and even large improvements may only result in a 1 or 2 point shift in the final score. So in MIPScast, we score each category and weight them appropriately. This is also based on your APM participation selected, so we have those alternate weights built in there. We provide you visual feedback in each category, so there is some numerical scoring that we provide and also some color coding to indicate where you're performing well and maybe where you're not performing so well, so you know where to focus. You can download PDF reports of these scores, including a lot of detail about each of the categories, so that you can access that information without logging into the application. So save that to your computer and then you can access it anytime. You can run multiple scenarios. So again, if you want to check the ACI category for multiple 90-day periods, if you want to try running a scenario with a reweight on the ACI category because you qualify for a reweight there, if you want to enter lots of different quality measures over varying time ranges as the year progresses, you can see how you're tracking over time. This also allows you the ability to enter partial data for a score prediction, save it, and come back later and finish. When we look at the MIPS final scores for 2017 and we do an analysis where we, because oftentimes practices or clinicians complete multiple scores throughout the year, and we look at just their best score for the year, what we see is that the average in terms of a mean is about 67% and that the median is about 70%. So, and this is roughly in line with what CMS reported at the end of 2017 in terms of what they saw with who was meeting that exceptional performance threshold. And as Bruce mentioned, as we're moving away from arbitrary thresholds like 3 points or 15 points and moving more towards looking at an average or a median score or a 50th percentile score, it's very likely that that score is going to jump up closer to in between the 70 and 80 point range. And what I've seen thus far in the 2018 performance data is that the average scores are actually higher in 2018 than they were in 2017. Some of that is related to the benchmarks for some of the quality measures have changed as CMS has collected more data. A lot of practices and clinicians are more savvy. There may be practices and clinicians that are fully participating in 2018 where they were just participating minimally in 2017. There are also multiple bonus points and other rule changes that are available in 2018 that were not in 2017 that are inflating scores some. So our expectation at the end of the year for 2018 is that these mean and median scores will be even higher. When looking at these scores a little bit deeper, before I had this data, I was expecting obviously that the quality category and the promoting interoperability category would be the biggest determinants of the final score because they're weighted the highest. I was also, however, expecting that perhaps there would be a relationship between practices participating in improvement activities and having higher quality scores, or that practices that were using their certified technology very effectively in scoring high in the promoting interoperability category would also have higher quality scores, and that typically I expected to see that a practice that scored well in one category was likely also doing well in those other categories. Instead, what we see is that there are no strong correlations between the categories with each other, and we also don't see a strong correlation between your improvement activity score and your final score. So as Bruce is hovering over this chart in the upper right-hand corner, the scores roughly fell into two groups. And so that group that he's hovering over now, that's kind of to the left, those are practices or clinicians, quality scores, and final scores related to each other very closely. It's a very linear pattern. And these are groups that did not meet the base score on ACI or PI. And so what you can see is that there are practices or clinicians that were getting 100% on the quality category, but who did not meet the base requirements for promoting interoperability. Likewise, in that second group that's a little bit further to the right, those are the practices or clinicians that did meet the base score in the promoting interoperability category. And you can see that there are practices and clinicians that did very well in the promoting interoperability category who had very low quality scores. And so there was not a relationship between the quality category and the promoting interoperability category. And I think that was the most interesting piece of data that we saw when we looked at the way that the categories relate to each other. So the next couple slides are going to be high-level summary, essentially packaging up all of the recommendations that Bruce and I have talked about over the last several slides. So first, I would just like to say that if you are a low performer or you have a low score, you're not going to be able to improve every category all at once overnight. And so what we'd like to advise you to do is to prioritize which category you can improve that will have the biggest impact on your final score. And essentially that will not probably be the improvement activities category or the cost category. So you're really going to want to focus more than likely on the quality category and the promoting interoperability category. Within those categories, if your promoting interoperability category is at 0 points because you're not meeting the base score, that is going to be the biggest areas where you can make an improvement in your score. So if you're not meeting the base points requirement in the promoting interoperability category, I would start there. If, however, you are meeting that, then I would definitely focus on the quality category. And within the quality category, again, there are some tips to focus in even more narrowly there and focus on just a couple of measures. You can also contact your registry or EHR and see if there are additional measures you can report that maybe you hadn't thought of or didn't know if they were available to you or may not have thought that they applied to you clinically. There may be measures there that you can get additional bonus points for or that you may not think you're scoring well on, but you can submit anyways, and perhaps a benchmark is established for those and you can score higher than you thought. Again, if you submit more than one set of data, so if you submit claims data, EHR data, etc., CMS will score both and use whichever is more advantageous. And then again, really drill down to a couple quality measures that you think have opportunity for improvement, that are not topped out, have a benchmark, and that you have the ability to report.
So to wrap things up then, as you can see, participating in MIPS requires a great deal of data collection and analysis with all these different facets, different options, and every one of them is going to affect that final score. So you need to be able to track several categories of information, some of which may overlap and affect other categories. It's really complex. You need to be able to track those changes over time. You need to be able to evaluate the various reporting options and how they're going to affect that MIPS final score, especially under that quality category. It makes a massive difference. You need to be able to easily identify those areas of strength and weakness to determine the best improvement strategy. As we said, none of us have enough time to focus on everything. So you've got to really narrow that focus down to where you're going to be able to make the best improvements there, the biggest bang for your buck. And while you certainly can do some of this manually, I find it difficult to see how you can really do it comprehensively and really get that great picture without using some sort of tool that can track and trend and analyze that data to help you more easily narrow in on the best improvement strategies that are going to boost those final scores. We want to point out also that aside from those from the MIPS cast or those other programs that are also available to you, there is technical assistance available to absolutely everybody that needs it. You are not alone in this. CMS has set up a great network of providers or of service providers that can help you. We are one of them. We are the small, underserved, and rural practice support. Not just here in Michigan, we actually cover a 7-state collaborative around Michigan here, and I know we have folks from around the entire collaborative. If you are a small practice provider, 15 or fewer, billing clinicians, please give us a call. Email us you can go to our website, QPP Resource Center, interface with us there. We would be happy to help you. It is zero cost. If you are a large practice provider, 15 or more billing clinicians, here in Michigan anyway, you can connect with Holly. I've got her information there. She is at MPRO. MPRO here in Michigan is ready and waiting to assist you as a large practice provider as well. If you are not in Michigan, you can still reach out to us through the small, underserved, and rural practices email there, and we would be happy to connect you to whoever we can get you to get you the free technical assistance. But nobody is alone out there.
We do have one poll question for our audience today. We would like to know how satisfied you are with the information we provided. Your answer will be on a scale from 1 to 5, with 5 being very satisfied. Please use the radio buttons to choose your answer. We know that we went slightly over on our time today, and we appreciate everybody sticking around. We did get a few questions during the presentation, but since we are over on time, Bruce and Jacob are going to answer those questions through email. So you will be getting a response to your question shortly. Thank you everyone for answering the poll question, and thank you everyone for attending today. Again, if you have questions, that is our email address. You can call Bruce, you can call Jacob, and a recording of this presentation will be available at www.qppresourcecenter.org tomorrow. Thank you everyone for attending.